Hi, good afternoon. I'm going to be presenting today on the topic of from subjective to objective tools to use for end-of-life discussions with ALS patients. My name is Shivangee Thorne, and I did this presentation in collaboration with my colleague Louise Frumkin. We are both clinical social workers at the Carolinas ALS MDA Clinic, which is in Charlotte, North Carolina. So my objective today is to hopefully offer other multidisciplinary teams good tools to use to improve and encourage end-of-life discussions as a team approach. So the social workers in particular and our multidisciplinary team in general identified some concerns within our patient population. So there was a noticeable increase in the number of unplanned or emergent tracheostomy placements amongst our patients, and also noticing that we were missing referrals to hospice or making them pretty late in the disease process. We also noticed quite a bit of distress for patients and caregivers as the disease reached its end stages, increased stress in the home, increased stress with the actual physical caregiving, and an increased need for additional support beyond just what we as a clinical team in an outpatient setting could provide. And lastly, for us as a team, there were some very differing viewpoints about what those kinds of big decisions at the end of life meant and how that was presented to patients and families. So we wanted to be able to provide patients and families with consistent and accurate information about these important topics. And for those patients who chose tracheostomy placement, because in the U.S. that is a elective and optional procedure, we wanted to make sure they were prepared for all of those pieces of what life with that new device would be. And we wanted to make some improvements for ourselves as a team. So we wanted to reduce some friction and confusion about how we all were interacting with the same patients. And it was important to normalize those discussions about end-of-life care. Those are not easy discussions. Most folks aren't trained to have them. As I was famously taught by a chaplain friend, many people find death to be optional, so we don't talk about those things. And then yet, here we do this work, and we have to be able to talk about that. So in the past at our clinic, these discussions about end-of-life care, disease process were kind of primarily led by social workers, sometimes by physicians and other providers, but primarily social work was doing that. And the indicators for when to start that discussion were kind of subjective. It was a gut feeling. Of course, everyone's gut's a little different, so it's not consistent across the board, and we wanted to improve that. And there were some concerns across this team about when are you bringing up hospice? Why are you bringing it up? There's concerns about the things that patients maybe would not be able to get from a payer standpoint once hospice began, continuation of volume ventilation, new equipment that they may need along the way, these kinds of things. There were some misunderstandings about what hospice did or didn't do, or misunderstandings about just that they were a limited service. And again, the discomfort about talking about end of life. As with anything, all these discussions started out pretty informally. It's case by case, oh my gosh, this happened to so-and-so, and should we have done it differently, and what do you think, and whatever, and then it becomes a little bit more formal. There starts to be some collaborative emails or discussions at meetings, and one of the big concerns that came up was when patients were being referred to our sort of US model of hospice, many of them were losing access to volume ventilation, and that was a concern for comfort and care. So one thing that happened was that our nurse coordinator and our medical director had ongoing conversations with a local hospice to discuss the importance of this and arrange for that to not be a barrier anymore. The couple hospices started to agree to provide that to our patients. And lastly, what we did as a team was we collaborated to create 2 specific handouts, and that's primarily what I kind of want to discuss here today. These were all created over time, over several meetings, with the whole team's involvement and approval by all the providers before they were ever given to patients. So the first document has to do with points to consider when thinking about hospice. So this is the first one, and it was kind of a trial. And it's really brief. It's some more of a frequently asked questions, if you will, but it is geared specifically to ALS patients. There's lots of documentation out there about what's hospice, and we hoped this would be more specific for our patients. And I think that they appreciate knowing that those providers that are providing care to them are the ones that wrote this, that they know that it was with them in mind. So start out with the basics. What is hospice? It is important to explain that hospice is a service geared towards folks at the end of their life. It's intended for folks who would benefit from additional comfort care and would have primarily care in their own home. The next question is, well, what am I going to get out of it? What are they going to give to me? So we made sure to describe who all would be on the hospice team, that they would have a nurse, a social worker, a chaplain, they could have volunteers, that there was a nurse to call in an emergency so that they didn't have to call 911 if there was an event. And that for the families, that there would be 13 months of bereavement support thereafter, so that it was a wraparound service. And we talked a little bit about what are the qualifiers for folks with ALS for hospice. One of the big qualifiers we pay attention to is forced vital capacity, being at 30%. And so this gets again to the making it more of an objective indicator, right? Where it's no longer our gut, we're finding clinical information. Also, significant trouble with movement, significant uncontrolled weight loss, and several other kind of indicators that are listed here. We invited folks to consider the pieces that they might want to think about before accepting hospice. A lot of them have to do with billing concerns. So if your insurance is paying for caregivers in your home, will that be affected by including hospice? Let's try to find that out. Are you waiting for some large piece of equipment that maybe it's better to receive that equipment and then initiate hospice, so on and so forth. Now, this is the biggie. This is the big question you get from all the patients. So if you're telling me I need hospice, does that mean that you think I'm dying tomorrow, and are you going to stop treating me? Right? That's the big question. We still get it all the time. And the answer is not at all. Hospice is merely an additional service. It is more, not instead of. You can keep coming to us. You can call us as before. We're absolutely behind you, but we're not able to be in the home with you. So this is just to provide you more. And then, of course, lastly, who do I talk to if I want to enroll? So we were providing this document for probably 6 months or so before we thought, it might be helpful to also talk specifically about the all the kind of obstacles and things to consider with tracheostomy care. And so we met again as a team and came up with another document. And so the next one has to do with tracheostomy ventilation. It's a complicated issue, so this document's a little bit longer. And it has to do with just describing when a trach might come up. Why would that be? What's the difference between that and other types of respiratory support? The difference between having that as a scheduled procedure versus having it in an emergency setting, and why we suggest people start to think about those decisions earlier rather than later. We talked about like the nuts and bolts of what it's like to have the procedure. How long will you be in the hospital? Who will take care of you? These kinds of things. And then we talked about what care at home might be like. So this is obviously also geared towards caregivers, what they might need to consider as families make this decision together. There's a reference to a particular YouTube video that shows a ALS caregiver providing care to somebody who has ALS is on a ventilator, so that they maybe would find that useful. And also what the opportunities for providing care in a facility might be, and how that might look. There was definitely important to include communication and swallowing concerns. I mean, without communication, a lot of other stuff is really hard to handle. So, what is that going to be like? What will change for me, if anything, with this procedure in terms of communication and swallowing? And then we felt important to share what the progression of ALS will be like even with the tracheostomy, that the tracheostomy does in fact assist with breathing concerns, but that the other parts of the disease will continue to progress as before. And then the last page is kind of a sum up, advantages, disadvantages, just a quick reference. So these documents are usually provided to patients when they come to multidisciplinary clinic. They're sometimes provided at the first visit, although often it's too early. The social workers do make a point of talking to all patients about advanced directives, starting from the very first clinic visit, so at least introducing the topic of healthcare power of attorney, living will, introducing the fact that we're the ones who will continue to talk to them about that, again, that normalizing that. And then at every multidisciplinary clinic, we again address, do you have questions about long-term goal planning? Can we answer those questions? What can we do for you? So my approach, and I think most folks on the team, is to have the conversation, often including what's on these documents, and then provide that for a take-home. Because we all know they come to the clinic, they hear from a million of us and thousands of pieces of information, and they're not going to remember. So this at least provides them with something to reflect on. And we do hear back from them. I read that thing you gave me and I have a question, or I showed it to somebody else in the family and they wondered about X, Y, and Z. That document, as I mentioned, is available to the entire team on a shared network. It's provided also for physicians to give to patients, and they have been, so that we're trying to make it a full team activity. So in addition to these documents, as social workers, we provide an email to the entire multidisciplinary team a couple days before clinic, and that email generally talks about which patients we've identified as being in the range of probably needing to start to have those conversations really specifically. So based on things like forced vital capacity, weight changes, and other concerns. And then prior to our monthly ventilator-only clinics, we just discussed those patients at that meeting, specifically caregiver concerns, communication, or locked-in status. And our next step is a collaboration with our local hospice to be providing an in-home palliative care program specifically geared towards neurological patients, because in our area most palliative care programs are in an outpatient setting and most of our patients can't get there. So we're hoping that this is going to be a good collaboration. It's just started about a month ago, so we'll kind of see if that's just another benefit. And that's my contact information. Does anyone have any questions?
Thank you. Okay, so we do have time for some questions, so hands up if you've got a question, please. Yeah, okay, one at the back.
Hi, I'm Ashley, and I'm from the St. Louis Regional Chapter. And this is often a phenomenon we see with patients when we broach hospice, is that they sort of gravitate towards palliative care. And in the Midwest, I don't know if it's something that's sort of up and coming on the coasts, but in the Midwest, it's not really an option. And I don't know if you guys have sort of an idea of how to facilitate transitioning from palliative care into hospice, or how you're going to kind of address that, which patients are more appropriate for palliative care versus hospice, et cetera?
So our discussions with the palliative care folks, and for us, it's one organization that has both programs, is that it would be a collaboration between our team and their team. So we know that sometimes they'll only agree to palliative care because that feels safer, even if they're probably already hospice appropriate. But what they have noticed as a palliative care team is as they get to know the palliative care staff, they start to realize, okay, these aren't the death nurses coming in to off me. They're nice people who are here to help me. Okay, so maybe that might be okay. And it's also a good time for folks to say, oh, my caregiver is really finding that they need more help. Right? So often that is the discussion for even hospice for us is this is additional help for your caregiver, which I think, again, is a little bit safer way for folks to start to think about having this support come in, and is a way for us to get it in earlier so we're not doing those delayed referrals. And then they get comfortable with that team and turn to them as their needs increase.
Thank you.
Yep.
Middle.
Hi, I'm Mary Beth Geis with ALS Care. I live in North Carolina as well. Now, I did not realize that Dr. Brooks now has a ventilator clinic. So does that mean that just the ventilator patients come to that clinic? The reason being is that sometimes when there's a ventilator patient at the clinic, when there's regular patients, it gives the other patients an opportunity to see what a ventilator looks like. Previously, when I was in Houston, if a patient, back in the 80s and 90s said that he wanted to go on a ventilator, I would make sure that they got an up-close look at life on a ventilator. And I had a few patients that were willing to let another patient come to their home and see what it looked like. Sometimes patients on ventilators, depending on whether they still have their speech, can make life on a ventilator look like it's not such a big deal. I think patients need to see it up close. So again, do these ventilator patients ever come to a regular clinic?
So it's kind of mixed. We do provide a specific ventilator clinic just for those folks, mostly for their convenience. It was just, many of them were saying it was just too much for them to be there at the full multidisciplinary clinic. And so that was, to meet their needs. But there are several patients that we have who say, I want to keep coming to multidisciplinary clinic. I know my folks that come on this rotation and they're fine to be there. So we sort of have a mix right now. And I agree with you. Sometimes that there's nothing that replaces actual knowing somebody. There's no way to do that. So one of the other things that we've done is said, if I can find somebody willing to talk to you, would you like to have communication with somebody who's already on a ventilator? When we have patients who are starting to explore that route and aren't sure how they feel about it. So we've tried to connect them that way. I have found a very old list of folks who are willing to have that discussion, and one of my projects for the coming year is to update that list.
Thank you. And I've got one final question right at the very back. There won't be time for another one after this.
Hi, Nicole Hutchinson from Australia. What percentage of patients actually go to hospice, and is your stats consistent with what happens elsewhere in the US?
I don't, unfortunately, actually have the raw numbers. We do know that they have increased a little bit, and we're hoping to continue to increase that. I think what we're finding is what we're really increasing is how long that they're on hospice, so that we're referring them much earlier than the last 2 weeks or the last 10 days, which we think is a benefit, but we definitely have a lot of room for improvement in that area, and so we're definitely working on it.
Okay, thank you, Shivangee. Thank you.